Annette, that's very kind of you, and some of it's even true. So thank you very, very much. Thank you to Annette and Annetta and to Freda and to Lauren for inviting me once again. It's an absolute pleasure to be back in Oslo, beautiful city. And it's even more of a pleasure to see all my friends in the FFN. So that's you lot. That's all of you. Did you know that you were my friends? Some of you are looking slightly nervous now. But that's why I'm here, because actually this meeting, as Freda said, is not about presentations. I'll talk some nonsense. You can listen or not listen. The real meeting goes on in the reception, in the coffee areas, in the bar afterwards, where you get to meet all the people that you need to talk to swap ideas. So I spend a lot of time talking about orthopaedic trauma. Trauma surgeons love looking at x-rays and pontificating about bits of metal to fix bones. And it's really important. I can see none of you are convinced by that, except for the surgeons nodding vigorously. And I learn some things at those meetings, but I learn a lot more listening to my colleagues from other disciplines at the FFN, and that's what this meeting is all about. But what was my remit for today? Well, first of all, to enlighten you, and I know most of you are thinking that's unlikely with this speaker, but at least try not to confuse you any more than you were at the start. I'm going to talk a bit about the surgery. I'm going to talk about one specific area of the surgery and about the latest evidence in that area. And I'm talking about displaced intracapsular fractures of the hip. So this is the breaks at the very top end of the thigh bone, the ones just under the ball and socket, where the bone doesn't heal very well. So we tend to replace those bits of the hip rather than try and fix them back together again. So this talk is about arthroplasty, replacing the bits of the broken hip. So I'm going to talk about bits of evidence, some of which will be familiar with you. This is really an update on what we talked about last year, and then a new bit of evidence that's just come out in the last 2 or 3 months. So most of the work I do is funded by our National Institute for Health Research in the UK. This is the research arm of our national healthcare system, so it's taxpayers' money that fund this. But the new bit of research was actually co-supported and funded by Honorary, who I don't know if they're here at the meeting. They may not be when you see the results. But anyway, they very kindly supported this study, which was really important for our understanding of what to do for this important group of patients. So to go back 3 years, so those of you who were at the FFN meeting online from Canada that Lauren and colleagues organised will have heard Mohit Bhandari and colleagues, including Freda and other colleagues in this room, talk about something called the health trial. So this was a huge international effort to answer a really important question. This was about what type of hip replacement do we need to do for patients with this particular type of hip fracture. Over half the patients with a broken hip have this particular injury, this intracapsular fracture. And this study compared 2 types of implant, a partial hip replacement, or hemiarthroplasty, versus a total hip replacement, where you replace not just the broken ball, but the socket as well with a total hip. Now, most of us, myself included, thought that total hip replacement gave advantages to patients in terms of function, particularly in the longer term. So we reserved hemiarthroplasty for those patients who were frailer and older, which actually the majority of patients with hip fracture, but did a lot of total hip replacement for patients who were more active. Basically, anyone walking independently outside of their own home, guidelines certainly from the UK and replicated around the world suggested a total hip replacement would be better. So what did they find in the health trial? This was published in New England Journal. Well, the primary outcome measure was actually about failure of the intervention, so further surgery, which is an interesting choice. But for me, the more important information came from the key secondary outcome measure, which was actually quality of life after these 2 interventions. And to everyone's surprise, including mine, they found there was very little evidence of a difference between the total hip replacement and the hemiarthroplasty. And the hemiarthroplasty was cheaper, lower complication rate, and in many cases, the optimal treatment for patients with this particular injury. So it became clear that total hip replacement, although we still do that, should be reserved for the very higher functioning patients. So I did a total hip replacement on an 85-year-old the other day. Why, you might ask, when he had a displaced intracapsular of the hip? Because he did it falling off his road bike and he was cycling 100 miles a week, which is about 90 more than me. So I thought, you've earned your total hip replacement. But we reserve it for that very high functioning group of hip fractures. Now, the majority of patients seem to do just as well with a hip hemiarthroplasty. So the next question, which type of hemiarthroplasty? And this was a study that we did in the UK, also published in the New England Journal, 2 years ago now, or a year and a half ago. And this study was comparing 2 types of hemiarthroplasty. We included over 1,200 patients over 60 with a displaced intracapsular fracture. and randomised them to these two implants. So some of you will be very familiar with these implants. The one on your left is an uncemented implant. So this implant is pressed into the top of the thigh bone, and it's got a special coating on it that encourages the bone to grow onto the implant to grip it in the longer term. It's got lots of potential advantages, used a lot for hip replacements in arthritis, so lots of countries around the world. The one on your right is the cemented hemiarthroplasty. So around this implant is a grout. So when you fix the tiles on your wall in your bathroom to the wall, you use a grout to spread the load and press those tiles onto the wall. This is the same sort of thing. It's called a bone cement, and we use it to fix the implant to the bone. But we didn't really know which was the better implant for this group of patients. So what did we find in this study? Well, this was really interesting. I'm not sure I've ever had this with any trial I've ever been involved with before. But we found that the cemented implants not only gave improved quality of life to patients, especially in the first 4 months after the injury, the early phase of their recovery, they also had a lower complication rate, specifically a lower risk of fractures around the implant, probably because you didn't have to hammer it in as hard at the beginning. And also, it was cost effective. So not only was the implant cheaper, but actually the total cost to the patient and the healthcare system was less with the cemented implants by quite a way, mostly driven by reduced length of stay and by reduced follow-up appointments, particularly therapy interventions. So at the beginning of last year, and at the meeting in Melbourne, I was able to tell you that the choice of implants now narrowed down even further. We believe that the great majority of patients with this injury can be treated successfully with a hemiarthroplasty, and there's no doubt now that that hemiarthroplasty should be a cemented hemiarthroplasty. Okay? So a very clear take-home message from the data that we had. Next question, because there's always more questions, isn't there? What type of bone cement should we be using to fix the bone or fix the implant to the thigh bone? So this was a trial. This is the new evidence. Not presented this before outside of the UK. Was published just a couple of months back in The Lancet. And the health economics data associated with this trial is just out 2 days ago in the Bone and Joint Journal for those of you interested in the economics of this. So this study was a much larger study, nearly 5,000 patients, individual consent for these patients, randomized to 2 types of bone cement for their fragility fracture treated with a hip hemiarthroplasty. And the outcome we're interested in was actually about infection. So why infection? Well, infection is a problem for any surgery. For orthopedic surgery, where there's metal implants, it's a real problem because getting rid of infection around the implants is incredibly difficult. And in older, frailer patients, our hip fracture population, it's almost impossible to get rid of that infection. So just to put this into context, the literature to date shows that around half the patients who get a deep infection after their hip hemiarthroplasty die within hospital. They don't survive to get outside of hospital. And those that do survive have much reduced quality of life, much longer hospital stays. So it's quite a big problem. It's a rare problem, but a really, really big problem if you get it. So we wanted to know which type of bone cement would reduce the risk of infection the most. So we compared 2 types of very popular bone cement. And this is where the manufacturer came in to supply the interventions as well as paying for some of the costs for the trial. One of the bone cements, the standard bone cement, contains a small amount of one antibiotic called gentamicin. And that elutes out of the bone cement, and that reduces the risk of bacteria adhering to the implants, creating this film around the implants that's almost impossible to get rid of. The newer intervention contained a high dose of gentamicin, but also a high dose of clindamycin. So we're effectively comparing a standard dose antibiotic cement versus a new double antibiotic, high-dose antibiotic cement. The idea being that the high dose of 2 different antibiotics would reduce the risk of infection. So does anyone want to see the video? Vague nodding, that's all I'm after.
A broken hip is one of the most common injuries for which older people in the UK need treatment in hospital. It is a serious injury which affects people's mobility, independence, and quality of life. Half of these injuries happen right next to the hip joint and are treated with a partial hip replacement. Doctors replace the top of the thigh bone with a metal implant. This implant is fixed to the inside of the thigh bone with bone cement. The risk associated with this sort of operation is generally low, but sometimes people get an infection in the area around the hip replacement. Only a very small number of people will get an infection after their operation, but when this does happen, it can be very serious for the patient. To try to prevent an infection from developing, antibiotics are added to the bone cement used to fix the implant in place. Between 2018 and 2021, the University of Oxford coordinated a large study called World Hip Trauma Evaluation 8, White 8 for short. White 8 was designed with the help of researchers, healthcare professionals, and members of the public across the UK. The study checked if adding different types and larger amounts of antibiotic to the bone cement could help stop infection from happening in more people. This study involved nearly 5,000 people, aged 60 and over, treated for a broken hip in hospitals all over England. A process called randomization was used to split the study participants into two groups. The participants in each group had similar characteristics, such as their age and gender, so the comparison of the different types and amounts of antibiotics would be fair. One group had their broken hip fixed with a bone cement with a standard amount of antibiotics. The other had their hip fixed with a bone cement with two types of antibiotics at a higher dose. 90 days after their operation, study participants or their carers were asked if there were any signs of infection. Hospital records were also checked for information about any infection around the hip replacement. Participants in the study were asked questions about how they were feeling, how well they could walk, and how much care they required. The cost of using each type of bone cement was also studied. The study found that there was no benefit in increasing the amount or adding different types of antibiotics to the bone cement. Only a very small number of participants from each study group got an infection. 4 months after the operation, there were no differences in quality of life, pain, or mobility between the groups, and an equal number of participants had died. The standard bone cement was cheaper for the NHS. Overall, we recommend that hospitals use bone cement with the standard type and amount of antibiotics in patients who were given a partial hip replacement for a broken hip.
So, what do we take from that? Well, two things. Firstly, that audiences much prefer listening to the video than listening to me with figures and slides. That's become increasingly clear. We've had to stop that study early, comparing me with slides versus the video for futility. It was utterly clear that everyone preferred a video, including scientists and clinicians as well. Those videos are actually made by our patient and public involvement members. They script those, and then we work with a company to design this sort of video. So they're deliberately aimed at the public. But fascinatingly, they're much better at getting the message over to orthopaedic surgeons as well in there. I've got the figures if you want to see them afterwards. I'm not seeing any takers at the moment around the room. We have got the detail if you want to go into that. So two things to take away from that. First is that orthopaedic surgeons, that's you lots of my colleagues in the room, randomised 5,000 patients into an individual patient randomised trial. And that just really wakes up the rheumatologists in the room who thought they were the only ones capable of randomising that number of patients. Some nodding from colleagues on the front row here. So orthopaedic surgeons did that. The second is that contrary to all of the evidence that was out there in the increasing practice, it turns out that the dual antibiotic cement doesn't necessarily reduce the risk of deep surgical site infections, certainly not to the point where it becomes statistically significant. And the cost of the extra cost of the cement actually drives most of the economic analysis. So it's around £200 more expensive per case to use that bone cement for no obvious benefit to the patients. So sometimes the cheaper intervention wins again. So where are we now with the treatment of patients with displaced intracapsular fractures of the hip? So if you're having a hemiarthroplasty, it's now become clear that high-dose dual antibiotic cement doesn't reduce the risk of infection. There's no difference in health-related quality of life, particularly in the first 4 months, but it is more expensive. So where are we now? Well, it's become clear that the great majority of patients with this injury, which is the majority of hip fractures, do perfectly well with a hemiarthroplasty rather than a total hip replacement. The hemiarthroplasty should categorically be cemented. We can talk about the nuances of that all day, but it's now absolutely clear in all of the evidence, all the evidence synthesis, that cemented implants perform better than uncemented implants. And this evidence suggests that single standard antibiotic-loaded cement is perfectly adequate for treating your patients with a hemiarthroplasty. Thank you very much.
To do anything? Oh, I turned it off. Okay, Matt, we do have some time for questions, so please, are there mics on the table? How are they doing questions, Annette?
It is also possible to send the question via the app, and I'll get it here on the iPad. Or you can stand up and
yell at Matt.
yell it, or perhaps we have a mic.
Could we advance the slide one more, please? Is that okay? So the thing that's most important that I forgot was to thank everyone that was involved in this study, some of whom are in this audience. There's a massive number of people, over 200 investigators involved in these studies. And it's a real collaborative sort of effort, so I'm very delighted to be able to present on their behalf, but actually most of the work is done by colleagues up and down the country.
Yes, please.
Do we have a microphone?
Oh, it's coming. Sorry. Thanks very much.
You can shout at me, son.
I can shout.
Okay.
Thank you very much for a good presentation. I'm Søren Warwick from Denmark. I think I have 4 questions.
Best wait for the microphone then, sorry, if you've got 4.
Brilliant presentation. Thank you so much, Matt. Pressurization of the bone cement. The X-ray you showed has a whiteout with a cemented exit stem. What do you recommend regarding pressurization?
So good question. So the one of the drivers for doing the White 5 trial, which was cemented, uncemented, was bone cement implantation syndrome. So the anaesthetists in the room have got just a raise in their blood pressure, which is associated with a drop in the patient's blood pressure when we pressurize the cement. Now, I think many of us believe that actually just instrumenting the femoral canal causes changes systemically that affect the patient's blood pressure, and that the pressurization of cement may or may not be an important factor. I think that's somewhat unproven. But guidelines in the UK suggest not pressurizing in the way we do for a total hip replacement for this group of patients, Søren. So I don't formally pressurize, but to be honest, when you backfill the femoral canal with cement, it's pretty well pressurized already. So how much difference that makes, I'm not sure. But we don't recommend active pressurizing the cement these days.
Thank you. Next question is about activity level. We sometimes, in my section of the department, I'm more a trapezoid surgeon than a fracture surgeon. I actually do not acute fractures. But sometimes we get a patient where the trauma surgeon has said, this patient have high activity level and you should do a total hip after a femoral neck fracture. And then we go to the patient and asking about activity level. And it always turns out that this activity level is not that high as it was supposed to be. So I think it's very difficult to say, well, this activity level, now it's a total hip, and this is a hemi. Which rule of thumb should we use? I think you should be very detailed when you talk to the patient, but do you have any rule of thumb?
So I think this is a really good point, and this is where the evidence shifted for me a lot after the health trial. Because I thought, and the guidelines were, certainly the UK guidelines and emulated in many countries around the world, where if you walked independently outside your home, even if it was with a stick, you probably benefit from a total hip replacement. We no longer believe that after health, and practice in the UK has certainly changed dramatically. So if you fall from a standing height and break your hip, you're almost by definition frail. Now, you may not know it, you may not associate yourself with that, and many patients don't, but when we do assessments on people, and see people in the audience much better equipped to do those assessments than me, you find out that actually many of them are actually quite frail. And those early, even if it's unrecognized osteoporosis and sarcopenia, are already evident in those patients. So for me, if someone's not broken their hip, they're in the fragility fracture age group, but they've not fallen from standing height, so the chap who fell off his push bike, that's a completely different injury. And that patient I would still offer a total hip replacement for. If you're doing a full round of golf, if you're cycling regularly, if you're playing tennis, you're probably going to benefit from less acetabular wear. And for me, a total hip replacement may still be the intervention, and we're waiting the long-term outcome from the health trial. But for the great majority of patients who fall from a standing height, my view is that a hip hemiarthroplasty is perfectly adequate and will give you equal function with a lower risk of complications.
Thank you. Can I ask a last question? Is it okay?
Aye.
About the COPAL study. Fantastic studies you have done. Thank you for those studies. This COPAL cement, you found 1.2% and 1.7.
Yes.
Between the two groups. I just read the abstract in Lancet. The confidence interval was quite big, but still there's a difference at percentage level, not statistical, but percentage level. So my question is about diagnosing these deep infection. That's very difficult, both in elective cases, but especially in acute cases after hemiarthroplasty. So how did you This is a really good question. Here's
the figures for no one was interested. You just wanted the video, didn't you? There are lots of numbers behind this. It's all available in the supplements through the publication in the Lancet. I can give you even more detail if you want to. There's whole presentations on this data set. It's quite fascinating. So someone's question is a really important one, though. So do you know that in the majority of papers from orthopedic world that report infection after hip fracture don't give a definition of infection at all? So we've no idea what we're talking about. So that question is really important. We use the Centre for Disease Control from the state's definition of deep surgical site infection related to an implant. So at 90 days, we look for very hard signs of infection, so pus from the wound, a sinus discharging, radiographic imaging of essentially pus in the wound, or culture positive samples from deep inside the wound. So really hard criteria for this. Defining superficial infection, as Soren knows as well as anyone, is very, very difficult. The diagnosis is fraught with problems of misdiagnosis and misclassification. So we actually, in a secondary analysis, looked at the rate of antibiotic prescription for other infections that didn't tick the criteria for deep infection. And there was no difference in that as well. But if you add those two together, there's a possible marginal benefit in favour of the dual antibiotic cement. So there's always nuance in these findings. But that's not statistically significant. At the moment, we're not advising it towards the dual antibiotic cement, but really good question, sorry.
Matt, just with regards to infection rates, there's many things that have brought down infection rates in orthopaedics, clean air environment, the antibiotics that we give intravenously. So how important do you think in general is antibiotics in the cement? You know, have you got a comparable trial to show that actually this is making a difference? So are you recommending that we should definitely have cement in our antibiotics in the cement? Full stop. Is there good evidence for that?
Yeah, so a really good question, Andy. So as ever with these trials, we get an answer to a very specific question, very small question. Some people argue not the most interesting question. I wouldn't necessarily disagree, but with that large cohort of patients, we've now got increasing data on what does make a difference. And it's reasonably clear from the literature and from the data we have, it's the actual systemic antibiotics given at induction intravenously that are the biggest driver for reduced infection. How much of that effect is the case now is difficult to work out. The evidence for that comes from the 80s, from the Lidwell trial, this was a very long time ago, where antibiotics wasn't one of the randomized comparisons, but drove the outcomes. The systemic use of antibiotics as prophylaxis was the most important factor. We started adding antibiotics to the bone cement because of that as an incremental effect. The evidence for that is not actually the best, so Andy's question is well made. Do we want to do a trial without the bone cement? I'm not sure I'd want to take that risk at the moment. The numbers we'd need for that, Andy, well into the tens of thousands, so you can do that one.
Mm-hmm.
I'm Ruthaga from Norway. I would just congratulate you on the great study on antibiotics and just a wider perspective than cost. So antibiotic resistance is a real and big and increasing problem in the world. And so it's really good that you have given evidence that we don't use unnecessary antibiotics.
No, thank you. And that's a really important point as well. So antimicrobial stewardship is something that's beholden on all of us. I think a message we're now hearing loud and clear, but not necessarily listening to. So reducing the amount of antibiotics we're using, particularly for prophylaxis, is absolutely key. Anyone here from the agricultural industry in the wrong meeting? Take note. Take note. Prophylactic antibiotics probably not necessarily helping us in the long term. But I think that's an important point. We should only use extra antibiotics if we've got really good evidence they provide benefit to the patients.
So, Matt, there's one question on the iPad that just sort of said, you talked about the large majority. Who are the minority? Sorry, they don't give me any context about which time you said that.
Sorry, repeat for me, Lauren?
The large majority, and then who are the minority when you're perhaps talking, sorry, whoever said this question, if you want to finish off the other part of the context of it, because that's the sole part of the question.
Oh, so for the total hip replacements?
For total hip replacements.
Yeah,
Okay.
So back to Soren's point, really. I'm now doing that in patients who had a higher energy injury. So if they didn't fall from a standing height, they had some other mechanism. They fell off the ladder and broke their hip. They fell off their push bike. They fell falling over the net, lunging for a volley, Boris Becker style. Then, they probably still are the type of person who will wear out the socket. So for those of you who are not orthopedic surgeons, if you put a hemiarthroplasty in, you've got a metal implant articulating with the cartilage, the articular cartilage, on the acetabulum, and that wears over time. Now, for the average hip hemiarthroplasty patient, that wear is very slow, and most of the patients, they die before the implant wears out. Okay, in the nicest possible way, it's a success from an orthopedic point of view. The implant survived longer than the patient. But if you've got very high function, if you're using that hip much more, so you're cycling 100 miles or you're playing tennis or so on, then there's a risk that in the longer term you will wear out the socket, and then the revision operation to do a total hip replacement is much more complicated. So many of us, I think most surgeons in the room, can I get a show of hands who's still doing some total hips? Okay, I think probably from the proportion of surgeons at Netta showed, then that's probably most of us still doing total hips, but for much more selected patients. So for me, who is that? It's the people who are higher functioning than me with my arthritic hip. So if they do more activity than I do, they definitely get a total hip replacement. I still consider myself young enough to get a total hip.
Thank you.
Thanks very much.
Oh, wow.
I just have to show you